We're ready.
All right. Hi, everyone. Can everyone on Zoom hear me? I'll do that quick check first. Can I get someone in the comments or Q&A saying something?
He raised hands, so I think that means that.
Yes. Okay. See, yes. Okay, great. All right. Okay. Thank you, everyone. Welcome. Thank you for joining us in person and on Zoom. My name is David Reiner, and I'm the Chief Science Officer for the California Initiative to Advance Precision Medicine within the California Health and Human Services Agency. We're here to celebrate 10 years of the initiative, or CIAPM, after being established in 2015 and continuously supported by the state legislature and Governors Brown and Newsom. We're recording this event just to keep as a record of this important milestone. Before we get started, I'd like to give a huge thank you to all the CIAPM staff who came before me, current and former members of our advisory council, some of whom are here today, and all our funded investigators and their teams, and all the participants that have engaged in the CIAPM funded study over the 10 years. CIAPM could not have lived on for 10 years without you all. You can see here on this next slide today's agenda. We have a brief overview of precision medicine and CIAPM to start. Then I'll kick it off to Richard Figueroa from the Governor's Office to give us some opening remarks. And then we're fortunate to have 4 of our investigators from across our portfolio give brief presentations. And then we'll have a panel moderated by our council chair, Dr. Claire Lajean-Cher. We'll end with some closing remarks from Undersecretary of CalHHS, Corinne Buchanan, who's also a former council member, and then close the talking part of the event and the Zoom part of the event, and we have some food in the back for the folks in the room to enjoy a short reception. So what is precision medicine? It's really a method of identifying the right treatment for the right person at the right time. And this important work aims to account for all aspects of one's biology, behavior, lifestyle, and environment to provide personalized and optimized health interventions. And you can really think of it as the right treatment for the right person at the right time. And what we do is we fund research that gets to that. So we fund precision medicine research, or research that gets us closer to whole person care. We've been around since 2015, like I mentioned, and we moved over from the Governor's Office of Planning and Research to California Health and Human Services Agency a couple years ago. We're a research grant-making program tasked with developing innovative technologies and personalized strategies for health challenges through a research to clinic to community pipeline and collaboration between research, clinic, and community along the way. And these grant-making efforts facilitate cross-sector partnerships and community researcher collaborations, as well as reducing health disparities. We require community partnerships in our grant making, and I think that's a key feature, and one of our speakers today is one of those community partners, so excited to hear that perspective today. That's it for my opening remarks, so I'd really like to now introduce Richard Figueroa from the Deputy Cabinet Secretary from Governor Newsom's office for some additional opening remarks and really supportive and appreciative of the Governor's Office's support.
Can you hear me okay? I have a big mouth, so there you go. So first of all, very, very happy to be here. I know some of you are joining from LA, and I wore blue and gold because I'm a Bruin, and the women's basketball team was in LA. Get that little plug in there. So anyway, good afternoon. Thank you very much for joining us. I'm Richard Figueroa, Deputy Cabinet Secretary in the Governor's Office. It's wonderful to be here today to celebrate 10 years of the program. I've been very lucky to work with precision medicine in this particular program since 2019 when I came on in the Governor's Office. And again, it's been a privilege to work with the different eras of staff members, leadership, council members, researchers during that time. A little bit about all the stellar work that CIAPM has been doing over the years, and there's a slide here that I'm going to kind of go through real quick. CIAPM has supported 21 research projects through $49 million in state-funded research. Those researchers have brought in about 102 or leveraged 102 million in additional funding, published 300 scientific papers, given over 500 presentations in national and international conferences, as well as the other metrics that you kind of see on this slide through the presentations, patents, clinical trials, validated technologies, new web resources, et cetera. I think that it's one of the wonderful things about this program is that, go to the next slide here, I think. Just click enter. Yeah, that works. There we go. What's really nice about what we've been able to do here as well is that our researchers have engaged over 200,000 Californians in research, mentored over 200 students, formed over 200 partnerships. And it was mentioned earlier, we were able to move, hey, Dr. Wilson-Jarrett, you just missed my big push for the UCLA Bruins. I'm wearing blue and gold. There you go. Anyway, one of the great things that we've been able to do is, although this program or project started in the governor's office a couple of years ago, it did move to the California Health and Human Services Agency. And one of the major reasons we did that is that, governors have limited lifespans, so to speak, or limited terms of 8 years. We wanted to make sure this opportunity was more incorporated more fully in state government over the long term. So that's one of the reasons we moved it from the governor's office over to agency, so that it would be able to live on, this opportunity could live on beyond the time of Governor Newsom. As David mentioned, CIAPM's grant making emphasizes community engagement by requiring community partnerships and research that aims to reduce health disparities. Particularly during the Newsom administration, these investments have supported Governor Newsom's vision for behavioral health and California for All. They kind of track generally his behavioral health work. He's interested in ACEs and looking at behavioral health and the impact of ACEs on young children, depression, other things that are related to behavioral health, as well as a very strong focus on equity. And so a lot of the projects that you've mentioned have been very focused on equity in communities of color and making sure that communities of color are able to fully participate in all the work and all the research that happens in California through our wonderful university and other kinds of systems. One success story I do want to share is that CIAPM supported pre-pandemic genetic research, which later helped identify and track COVID-19 variants, including the first known U.S. case of the COVID-19 Omicron variant, which of course was very, very active during a particular part of the COVID life cycle here, in collaboration with the California Department of Public Health. This story illustrates how state investment research can have larger impacts down the road in unforeseen ways. And our first speaker, Dr. Charles Chu, here, led that research. I'm also looking forward to hearing from him and all of our speakers today. We'll hear about how engaging community leads to meaningful impacts for Latino communities with or at risk of cancer, as well as stories about research to address health impacts of adverse childhood experiences and stress, like I talked before about ACEs. We know and look forward to the impact that these state investments in precision medicine will continue to have in terms of community impact, training and education, research excellence, and scalability well beyond the tenure of this governor. Again, welcome on behalf of Governor Newsom, and I'll hand it back to David to take us off for our speaker presentations. And poor David here is a little bit hobbled. Major injury here, so give it a second here to transition there.
ACL tears are pretty challenging life experience. Thank you, Fig, and now just wanted to kind of introduce our research programs, given kind of a preview of the presentations from our speakers. We've had 5 research programs over those 10 years. Started out with our precision medicine kind of proof of concepts research program back in the first few years of our CIAPM, and then followed by kind of program thematic based programs. So cancer disparities, and Isabel will touch on that. ACEs research program, we have Nita, Dr. Tucker, and Dr. Slavich to present on that, and Dr. Slavich also has some role in some of the depression work as well. And we have an active ongoing funding opportunity focused on representative research as well. So all these research programs get at different themes, different aspects of precision medicine, and really excited to introduce the today's speakers. We'll start with Dr. Charles Chu, professor from UCSF, to take us away.
David, could I ask everybody to put their mouth closer to the mic? It's kind of difficult, and it hasn't anything to do with my age.
Great, thank you, everyone. And I have the pleasure of beginning the talks here. It's been wonderful to see the California Initiative to Advance Precision Medicine flourish. We were one of the first 2 projects that were funded by the CIAPM. And I'll be talking today specifically about our project, which was titled Clinical Metagenomic Sequencing for Precision Diagnosis of Infections.
Charles, we'll pause for just a second. Oh, what we're going to do is we're going to stop sharing on your end. You can continue with this, and I'm going to share a slide on my computer in the background. Here's just one by hand.
I can put it closer. Oh, just a second closer. Great. So the motivation for this is that we face diagnostic challenges in infectious diseases. I'm an infectious diseases physician. I can tell you that up to 50 to 60% of cases of pneumonia, meningitis, or encephalitis, which is an infection of the brain or spinal cord, hepatitis or potential liver infections, and fever and sepsis, they do not get a diagnosis, and this is despite extensive testing. I quote some papers there in the hospital. And as a result, many patients who are admitted to the hospital with an acute illness, they end up undergoing a very long and a very painful diagnostic odyssey where we send test after test after test in an attempt to diagnose a patient's infection. And indeed, a large proportion of these may not even be infections. Non-infectious conditions, including autoimmune diseases or cancer, can mimic an infection, and it can look entirely be indistinguishable from a bona fide infection. And so our goal here was to actually develop a research technique that was developed in my lab called metagenomic next generation sequencing, abbreviated MNGS. And it's a very simple concept because nearly all pathogens that cause infectious diseases are made up of DNA or RNA. In principle, we can just do a single test to identify the full spectrum of bacteria, viruses, fungi, and parasites that cause infections. And so this is what we call a pan-diagnostic test. You don't need to target any individual pathogen like a SARS coronavirus 2 PCR, for instance. You can simply do a single test and be able to diagnose a wide variety of infections. And by doing so up front, the goal would be that you could then, following in the line of precision medicine, you can make a precision diagnosis that would lead to targeted and effective treatment for these patients and hopefully get them out of the hospital. And so our project was a 1-year prospective study where I had already validated this test in the clinical lab, in the clinical microbiology lab at UC San Francisco. This was a 1-year study, a prospective study that involved 8 hospitals nationwide, 3 in California. The goal was to consent, enroll patients, and then compare head-to-head the performance of this one test against all other diagnostic testing that's done in the hospital. And this is specifically for patients who have potential neurologic infections, meningitis, and encephalitis, as you can see there. This was an unprecedented partnership. It also involved collaborations with cloud computing companies to make sure that the analysis was automated, as well as partnerships with several hospitals and with industry. We also partnered with QIAGEN on this particular study. But we wanted to implement a clinically validated assay that has pretty good performance, 86% sensitivity and more than 98% specificity. This is a clinically validated test, so the results were used for the first time to be able to manage and treat patients. In addition to that, because this was a completely novel test, we implemented the concept of a clinical microbial sequencing board, which is sort of like the microbiology equivalent or in the infectious diseases equivalent of a tumor board, where you have a patient who has a given type of infection, and we want to be able to interpret the results from this test in light of a patient in clinical context. The overall results are kind of shown on the right. There were several cases that were diagnosed only by MNGS, meaning that this was the one test that clinched the diagnosis and enabled the diagnosis to be made in a timely fashion, of which the majority of those cases had direct clinical impact. I want to focus on one patient, for instance, who had a very unusual infection from a hepatitis virus called hepatitis E virus. But she didn't present with liver failure or with a hepatitis. She actually presented with encephalitis. And because they were unaware of the cause of the hepatitis, she was actually on the liver transplant list and was actually scheduled to get a liver transplant in 2 weeks later. But by making the diagnosis, she was able to avoid the liver transplant. We treated her with an antiviral drug for this medication, for this disease, and she responded. So it gives you an example of not only the effects on clinical outcomes, but also potentially the decreased healthcare utilization or costs for the hospitals. I want to also perceive that this one study actually led to us implementing this test nationwide. As you can see here, after the study, we actually started to implement this on a routine basis for patients all over the United States. As you can see, it's disproportionately for California patients, but we still are able to do testing across the United States as well as internationally. And you can see this gives you an idea of our cumulative spinal fluid volumes over time, that as a result of this one study, we were essentially producing kind of exponential rise in the number of tests. And in fact, it got to the point that we actually had to spin this off as a company because we could not be able to meet kind of the scaling up for the test. But to give you some idea, over 7 years, you can see that the results of this very mimic our CIPM study in that among the infections, you can see that big pink circle there. That's the proportion of infections that were diagnosed using this one test. And I'm comparing this one metagenomic next-generation sequencing test against all other possible tests that we do to diagnose infections, as you can see here. So we were able to show that effectively, not only can we diagnose infections, we can also result in estimated costs to the healthcare system. So these are basically modeling estimates which suggest that we can reduce the number of tests by 2/3, the fewer days to diagnosis, reduction in number of tests, and fewer days to diagnosis for both patients who have both infections as well as patients who do not have infectious diseases, autoimmune disease, for instance, because the test can be used potentially as a rule-out test for excluding infection. I also want to end by talking about how we've expanded in the meantime. So we want to expand actually beyond simply precision diagnosis of an infection. So now in addition to doing testing of spinal fluid, we're now doing testing of blood and respiratory samples. We actually have 2 assays that are currently under review by the FDA. So we're seeking to get regulatory approval for these tests. I'll also illustrate an example of pandemic surveillance where we use this exact same test to characterize the first cases of COVID-19 from patients who were aboard the Grand Princess cruise ship. And this was when the virus entered the United States, primarily through the San Francisco Bay Area. And you can see also we've been able to apply it for cancer detection. I'll actually give a quick shout out to the company. I'm a co-founder of a company called Delve Bio, which was a company that that actually spawned directly off of our success with this test and with this 1-year study funded by the CIAPM. This was a company that has achieved $35 million in Series A funding, and currently we've been partnering with, the company has been partnering as well with the CDC on pandemic surveillance, one of which is an example here, where we were able to detect for the first time the SARS coronavirus 2 Omicron variant in the US. And again, applying the very same metagenomic test that we originally developed and validated with the support of the CIAPM. I want to end by giving you kind of where we're going to go in the future. This is how our attempts to now extend precision medicine beyond infectious diseases. Because as I said before, patients who present with likely infections, they could very easily not have an infection. It could be cancer, it could be autoimmune disease, it could be a vasculitis. And so this is a recent case of a 15-year-old girl who had a past medical history of migraine headaches, was admitted to the hospital with headache, vomiting, nosebleeds, had a spinal tap, had a variety of different diagnostic tests. Everything was negative, including our test. So you might argue, well, is this basically a failure of this test? And she continued to have worsening symptoms and was transferred to the ICU. But I want to really highlight, now that we have the availability of thousands of samples from patients who have infections or who do not infections, we've now used AI and machine learning to be able to develop models that can help predict what type of condition a patient may have, even if the patient is test negative for an infection. And what you see are by these ovals here is basically red corresponds to viral infection, blue corresponds to non-infectious etiology, and the light green corresponds to other types of infections. You can see that the patient is way on the left, suggesting that this patient does not have an infection, but rather has a non-infectious etiology. So what is this? Well, we can even hone in because, again, this is all data generated from our test from our spinal fluid testing. You can see here now that the patient actually appears to have some type of solid organ cancer, and we can even precisely determine what type of solid organ cancer to show that the likelihood of a solid organ cancer is higher than any other possibility, whether it's vasculitis, malignancy, autoimmune disease, et cetera. And so you might argue, well, where do we go from here? Why would a 15-year-old girl have cancer? She has no family history. She just has headaches. So she was admitted to a cancer hospital. And I can say 1 week later, she was diagnosed as having an aggressive atypical teratoid rhabdoid tumor, which is a very rare cancer. And she was actually started on chemotherapy. Notably, the initial testing for cancer was actually negative. It actually required her to be readmitted once we found out that there was a possibility of cancer. So it really illustrates how we're leveraging all of the data that we're generating from these precision medicine efforts to extend even beyond infectious diseases. I'd like to end by talking, by acknowledging all of the partners for this particular CIPM funded study, as well as all of our partners in the community. I list here all of our partners in the San Francisco County and other county Department of Public Health and the California Department of Public Health who assisted us with all of our COVID investigations. And I'd also like to acknowledge, in addition to funding from the CIPM, the funding from the NIH, the Innovative Genomics Institute, from several foundations, and the George and Judy Marcus Innovation Fund. Thank you very much.
Thank you, Dr. Chu. I'd like to introduce our next speaker, Ms. Isabel Daron, who's the founder and executive director of the Latino Cancer Institute. And let me get your slides up.
Good afternoon, everybody. Good to see you. Thank you for joining us, Dr. Chu. I'm really embarrassed to stand here because that was too good, but I'll do my best. And I decided that despite all the fabulous work that was accomplished by the two organizations, institutions that I worked with, I wanted to share this through the community lens because, it ultimately impacts the patient and the community. And so I'm always thinking about how can we take this fabulous research and apply it. So that is where I am working from, but I think I already screwed myself up. So I'm going to tell you the first things first, which is what I think we got out of this as a community. We were able to lead a critical discovery in disparities, and I'll tell you more about that and how that showed up. We also were able to show that when science talks to the heart instead of the head, people respond, particularly those who are removed very far from the whole concept of science and its impact in their lives. Navigation, we know and have proved over and over and over again, is a critical bridge between community and institutions, including clinics. And building research capacity in communities earns understanding and trustworthiness. There is always a payoff if you have the patience, the time, and the investment of dollars to do the work. So on our first study, reducing cancer disparities through innovative community advocate partnerships, we called it Alcance, and that was to reach the goal. We were in Monterey County. You see the slew of participants here. Our Stanford leads, myself and Dr. Dale O'Brien, who were the community partners, and then our three, an oncologist and our clinicians. We partnered with the federally qualified healthcare system, where we were able to uncover some real systems issues that created barriers, and I'll mention that in a little bit. But the most important group of people were below, and that was our lineup of community healthcare workers. One of the things that I insisted that I, as a co-PI, wanted to prove was the value add of the community healthcare worker along the cancer continuum. And so that is how we instigated this program, and that was to put community health workers in the federally qualified healthcare system all the way through and into the cancer center itself. And so this was really critical for me to show that community health workers are critical to the workforce, the healthcare workforce, labor force, and that they are a different group of people and cannot be treated like you would inside the institution. They are invaluable as bridges between community and your clinics. And as I say, cancer does not begin at the clinic door. So you have to start in community. And so these were some of the things that we did, because when we launched, it was 2020 and there was COVID right in the face of everything we were trying to do. So we had one meeting in community and the rest we had to jump online and do a lot of work virtually. But our CHWs at the federally qualified healthcare systems were out in community. They went to the fields to talk about vaccines. They had health fairs to help people understand about screenings, Well Woman's Health. They also were standing in lines with cars coming through, passing out food, cardboards full of food, or boxes full of food. And you'll see our community advisory board there to the other side. Now, we had as many as 40 people in this community advisory board. Way too many. I don't think you can get work done. Maybe 7 good folks. So I go crazed when everybody wants to have a ton of folk on an advisory board when I think you get less done. And so, oops, I want to go back to that, sorry. But my notes are getting in the way, folks, sorry. And so and some of the work I'm doing now, I say, let's keep it to 7. We can get work done. But anyway, these are the things that our CHWs did on both ends of the aisle. They helped raise the need for and the safety of the COVID vaccine, particularly among low income, because obviously in Salinas Valley and with agricultural workers, we had a lot of patients and community members very unsure at that point in time, as everybody would recognize, about the vaccine itself. I remember one person talking about the fact that they were just implanting chips. And I'm sure you've all heard many of the stories and disinformation, but we were able, as a result of having those critical conversations, allay those fears. But we also distributed critical aid food boxes. We delivered resource lists for food pantries, rental supports, and other needs outside of your regular care, because we know how critical to answer those needs is outside of just showing up at the clinic and getting your care there. We hosted Facebook educational awareness workshops, and people showed up. We were available to answer patient questions and navigate them into and through screening. And we had regular meetings with the clinicians, especially the FQHCs. And what I loved was, after the meetings with the CHWs, 2 managers opened weekend clinics, because they all recognized that these folk were not 9 to 5. That's why they weren't showing up for care. So that had that impact. On the other end of the scale, with our CHWs who were in the cancer centers, they were working with mostly Spanish-speaking people in their 3rd and 4th stage of cancer diagnosis. And what they also learned was most of these folks didn't know what the heck they had. They didn't understand their diagnosis. They couldn't talk to the doctor. They were frustrated in the lack of knowledge and also had more fear as a result of that. And so what the CHWs were able to do was actually inform them, help them understand, help them prepare questions for the doctor, and opened up communication. They understood a little more about what precision medicine was all about. But one of the things that I thought was the most critical was they found out the needs external to that diagnosis. And once again, they found there were housing and food insecurity. There was a need for psychosocial support that they weren't getting, that they needed, one gentleman said, I need a pair of shoes. And another gentleman expressed his fear by saying, I fear I'm going to end up on a park bench with cancer. And these are the kinds of things you're not going to hear them talk to the doctor about. And these are the ways they open their heart to tell others who talk with them, look like them, understand them, that these are the issues I am confronting. Forget just the cancer itself. These are exacerbating my concerns about my cancer. So in addressing all these, I think we made great strides. And when they went back to the oncologist and they started asking him questions, the oncologist said, I felt a burden lift. And, you know, I thought that was fabulous. I thought that was fabulous because it is really critical that your oncologist also be able to feel well in the process. I think what we did was we increased the patient knowledge on their disease, so we enabled them to understand it. We had them commit to a care plan. There was, of course, the communication with clinicians, but most importantly, we identified major issues that were external to the actual diagnosis and the care, and that made a great deal of difference in the quality of this long-term care. We increased the patient and community clinic capacity for genetic testing. Oh my God, he loves to play with me. Very critically, we uncovered at the Federally Qualified Healthcare Systems, which wonderful people really engaged with us, but when we taught 155 women about family cancer history and how it could relate to cancer risk and therefore to genetic testing, we were able to test 154 women. We identified 100 women who were a potential risk. 33 women actually agreed to be tested, and it took us 10 months from the time we identified that first woman who agreed to be tested, 10 months to deal with protocol, policy, and payer issues at the clinic before we could get that first woman into the one clinician who could speak genetics and talk to them about this test. So we saw these barriers, and they're systems barriers. So they're not patient problems, they're systems barriers. How do we go to low income, underserved, Spanish-speaking and other monolingual patients and say, do this, and then they run into this wall? So I found, and that's the work of the Institute, it is to work on the policy side. And what we found out was that genetic testing and federally qualified healthcare systems is not a quality measure. And therefore they're not prepared to do it, and they don't have to do it in order to meet all of the qualifications of being an FQHC. What does that mean? That means I have to go to Washington. I have to go and attack the HRSA people. And so this is what becomes very, very, I think, difficult. And yet, to me, what was so invaluable about CAPM, because it put us in the room with these issues that we didn't know existed, and we were able to uncover them, and we're able to now take it to that next level. But we, just the fact that we were able to educate those women, and then, of course, the project ended and we left. So we don't know how many of the women actually got screened. And that's the frustrating piece, because there's no follow-through, no ability to follow through. The other thing was that all of the CHWs who were there were also gone by the time the project was done, because they didn't keep them. And this is my frustration, because we wanted them to be built into a system without getting sucked up by the system and no longer doing what they were there to do in the first place. So you need that constant oversight and that guidance and that collaboration with community. I want to move on to the second project. So this was with Dr. Yolette Ziv over at UCSF and Laura Fetterman, who's now here at UC Davis. But we did two things. We wanted to understand genetic variants that cause breast cancer in Latinas, and we wanted to increase community awareness of hereditary cancer and genetic testing again. So we were, as a result of this project, able to identify some genetic variants that were associated with increased breast cancer risk in Latinas, very specific to them. Because oftentimes, too often, it frustrates the heck out of me, is that too often Latinos are seen as a monolith. There's no subpopulation, real deep dig into subpopulation. And we know we have populations of Latinas, thanks to Laura Fetterman's research that shows some indigenous ancestry actually is a protective, something that is protective with Southern European women, not so much. And so there's a differentiation. We also see there's a difference between Puerto Rican women and Latinas, Mexican women. So we know we need this deep dive to really unpeel the onion about how they might be impacted at a genetic level and at a risk level. Right now, we know 1 in 10 Latinas is possibly at risk for genetic risk. More importantly, we found 500 women who were under or unscreened when we educated by virtual, because it was COVID, we virtually educated 1,600 women. We found 100 who were possible cancer risk. 30 agreed to get screened, and because we paid the fare, they're getting screened. 6 have been identified as having a cancer risk. But we identified 500 women who were unscreened for cervical, breast, and colorectal cancer. It was COVID. You couldn't send them back to the clinic. Who knows how many of those ended up with late detection as a result of not being able to go to the clinic because they were not really supporting screenings during COVID. And so a lot of women didn't go. And some of them even said, well, I can't worry about that now. I have to take care of the COVID in the family. So once again, and with the navigation, it makes quite a bit of difference. But I'll tell you what is wonderful to me about how these things have impact over time. What happened, and here's some of the data that you can take a look at. But what happened that I really loved about our Tu Historia Cuenta project, which is the one I just described, is it has been adopted as a case study by the National Breast Cancer Roundtable, who just developed a toolkit on at-risk, I want to say, but at-risk and using genetic tools, and it's going to clinicians around the country. So our work has legs, it keeps moving on, and I think that that's really critical, that this can, as CIAPM likes to see, that its work is having, these cascading impacts. So some of the lessons learned were navigation at every stage of the process is essential. Barriers to testing for the uninsured is very high due to the cost. Well, is anything new? Doctor, you've been in this business a long time, and how much has changed? And now with some of the federal cuts, who knows what more is going to happen. So safety net FQHCs do not consider genetic testing a quality measure. This warrants policy change, and so we're going to work on that. And in coalition with a great number of other groups across the country, so that's going to help a lot. One of the most important things that also came out of this was that we actually asked the promotores who did the Tu Historia Cuenta and did the project to write a paper. I said, because it isn't just important for research to hear what these women who are doing the job know and advise, but it's critical for the community to see their own voices reflected in these research papers. And that knowledge, that their knowledge is really critical, their lived experience is super critical to any kind of research, so that we bring community to research and research to community. And so that to me is one of the things that excites me the most, that we can hear the community voice in wonderful research papers. So requirements, community partners need to be part of, need to be the co-PIs and part of the leadership. It also requires equitable fund sharing, because it's time and treasure that we put in, and community is of value. It brings valuable lived experience to the research, and so it needs to be done. And I think community sometimes uncovers things that research does not see, or it already knows things that research has not heard. And so it's really critical to have them at the table. And we're talking about a collaboration braided, in which there's the exchange of data. It's not all the work that you do as researchers doesn't just help research. It actually has some implementation opportunities for communities to start to develop some new best practices, some new education, going back into community, taking what they learned and putting it to practice in some level in some way. And so I think it's really critical that there's two-way learning. You know, they keep talking about community-based exploratory engagement, and I keep saying yes, but it's only one way in which someone actually, you know, wins or actually gets something out of it, and that continues to be the research side, not the community side. Until we see both equitably getting something out of collaborative research, I think it's going to be I think it remains kind of a dark eye for science. Let's see, do I have any? Partnerships come in many different ways. We as community-based organizations are very different. And I'm sorry if I'm over time here.
No, it's your last slide, that's why.
The structure will work, that works best for one group, and a particular partnership may not necessarily work well for another. It's contingent on many factors, including the goals and the capacity maturity of these organizations. Some are very well established, know what they're doing, can be, you know, really up to speed. Others need guidance and support, but they'll be solid once you help them and you earn their respect. So these partnership structures are not invariable. They can vary by initiative or partner, and they may change over time. But ultimately, I think that everybody gets something out of it, and the community, who actually is the taxpayer that supports these, gets a little bit back on their investment. Every community should get something back on their investment. So thank you very much. It's nice to spend some time with you, and hopefully we'll talk later.
We have a raised hand from Manali Patel. Would you like to?
We can do that in the panel.
Okay.
Yeah. Thanks, Ramon. Just to keep the speakers' presentations moving, our next speaker is Dr. George Slavich from UCLA.
Secretary Figueroa, Secretary Johnson, Julianne, welcome back. David, CIPM staff, thank you so much for this celebration. We're honored to be funded by this project. Happy birthday. I would like to talk to you just for 10 minutes or so about addressing stress-related disease burden at scale. Here's the good news and the bad news. Most of us living today will not die from communicable diseases. Since the 1900s, those have gone down thanks to better health care, more sanitary environments, et cetera. The bad news is we're more likely to die from chronic diseases of aging, heart disease, cancer, stroke, et cetera. What's one of the very obvious but oftentimes unassessed and unaddressed drivers of chronic diseases of aging? Adverse childhood experiences. This was the project that we were funded to investigate. Adverse childhood experiences were Secretary Figueroa briefly introduced. The canonical 10 ACEs, as they're called: childhood abuse, childhood neglect, household dysfunction, things like physical, emotional, sexual abuse, physical, emotional neglect, household dysfunction, including divorce. What is it about these ACEs? Well, they not only impact health, they impact a variety of other health and behavioral and lifestyle factors, but what I'm showing you here is that ACEs are implicated in 9 out of 10 leading causes of death in the United States today. Heart disease, cancer, COVID-19, probably not, obviously, in the initiation of COVID-19, but definitely in the progression, injuries, stroke, respiratory diseases, Alzheimer's, diabetes, chronic liver disease, and kidney disease. Think for the last time your own healthcare provider assessed your stress levels or your ACEs. So the irony I want to impose here is the paradox between ACEs being implicated in 9 out of 10 leading causes of death in the United States today versus how often you or your family or colleagues may have been assessed for their ACEs or stress levels. Why is CIPM funding so important and transformational, I'd say? Well, we can contrast it with the traditional funding approach that I would argue has failed us in some ways. Out of 27 NIH institutes and centers, most, as we know, are mandated to study disorders and diseases: cancer, diabetes, stroke, drug and alcohol abuse, and aging. Consequently, there's no systematic focus on studying preclinical risk processes like stress that, if addressed, could help prevent disease before it occurs. It's just not the mandate of those existing institutes and centers. Problem number 2, NIH and other funding organizations do not facilitate or require investigators to partner with healthcare providers, health systems, community organizations, or state or federal agencies. It's not that investigators can't do that, it's just that it's not necessarily encouraged or facilitated or required. Consequently, a lot of clinical trials get published, of course. That's the name of the game, but the expectations stop there. The likelihood of intervention getting adopted or integrated into clinical care is unfortunately relatively low. Problem number 3, like most funding, research funding organizations, NIH and other organizations focus on solving scientific problems. That's fantastic, but I would argue is just the first half of the translational pipeline. Most barriers to adopting and implementing an intervention or a medical device never get addressed in these funding schemes, such as patient usability and access, provider adoption, reimbursement problems. You can have something that works perfectly in a clinical trial that never gets integrated because those things are not part of the funding scheme or part of the goal of the funder. And the last but not least, maybe seems obvious, most of the money allocated to science is spent on research. That's great, but there are other things that are important for translation. There's a lack of support for initiatives that serve other critical functions like workforce development and training, ensuring interventions get translated and adopted, increasing public awareness around pressing problems in health and society. That's my preamble, so I want to show you how we address that with the encouragement, financial, and spiritual support of CIPM. We did a few things. I'll just briefly highlight them with a few slides each. The first part was the clinical trial that we ran, which was, to the best of my knowledge, the first precision stress management, scalable precision stress management program. What's the basis for this? When I'm stressed out versus when you're stressed out, it may affect different biobehavioral pathways. Secretary Figueroa is stressed out, maybe it changes his thinking style, his goals, plans, or aspirations for the future. Maybe for me, it affects my social relationships. Maybe for David, it affects his sleep or physical activity or eating. So the first thing we did was created a very short, scalable tool for assessing the extent to which any given person has problems in each of these 5 areas. And then what we did was develop a scalable, remote, completely decentralized intervention, 5 separate 12-week intervention programs, each of which had 3 components: 15-minute didactic videos so that participants could learn some skills, 30-minute online coaching sessions where participants in the study could self-book themselves for the coaching sessions, and 20-minute self-paced exercises. So just to paint the picture, if your risk score shows that your primary problem area is sleep, then you're tracked into the 12-week at-home scalable sleep intervention. If your primary problem is physical activity, stress-related physical activity, then you're tracked into the 12-week at-home physical activity intervention, all in the comfort of your own home. The primary outcome, which I'm showing here on the y-axis, is perceived stress scores, very well-validated outcome, perceived stress, the extent to which you feel overwhelmed, the extent to which you feel like you can't cope. On the x-axis, the 3 main time points: baseline before the intervention, follow-up 1 immediately after the 12-week intervention, and follow-up 2 is actually a delayed follow-up, 12 weeks following the end of the intervention. So the first panel just shows that the intervention worked compared to an active control and a passive control group, and then the other 5 panels are showing that it really doesn't matter which intervention you were tracked in, all the interventions are quite successful. The point here being that we profiled individuals and then targeted their specific biobehavioral problems. We have all the psychological and behavioral data coded, but of course, thanks to CIAPM, we are able to ambitiously assess a lot of things outside of the clinic. Again, no, we never saw any of these participants, only online. We basically took the lab in the clinic and took it to participants' home. They wore a wearable watch for heart rate variability, skin conductance, sleep, accelerometer, et cetera. Tasso blood collection kits for full multi-omics possibilities, urine collection kit for exposome assessment, stool collection kit for sequencing the microbiome, the saliva collection kits for genomic sequencing, continuous glucose monitors, and personal exposome devices to assess PM2.5 and PM10 pollution exposure in the local environment. The next thing we did was create a stress tracker. What's the problem here? COVID-19, how do health officials know where to intervene in communities where COVID might have hotspots. If you don't have a population-based tracking system, how can public health officials know which communities are suffering? Well, I would say the same goes for stress. If you don't know which neighborhoods and communities are stressed out, how are you going to deliver services that are targeted in a geographic manner? So we developed a stress tracker. It assesses just a few questions. This is the beta version. Each participant, each individual can track their own stress levels over the time, but you can also plot these stress levels on the neighborhood, the county, city, state, country level, just like you would with a COVID tracker. Again, all with the support of CIAPM. In terms of workforce training, we created the first, I think, free research training program to train individuals worldwide on cutting-edge research on training on stress, health, and resilience. This was interdisciplinary program focused on translational research on those topics, an 11-week totally online, completely free course. We ran our first cohort that included 125 individuals from 17 countries, 22 states, 93 universities. All the instructors provided their time in kind through CIAPM support. Some of us are in the UC system, Stanford, great universities, lucky enough to be able to have access to this training already, but many individuals can't. So CIAPM enabled those individuals who wouldn't otherwise have had training in these topics to get that training. Number 4, just 2 more. We created a massive open online course focused on self-care, social belonging, and service, a public awareness campaign and education campaign to enhance general awareness around the impact of stress, the importance of social belonging and connection on human health, longevity, and well-being. The MOOC is focused around these topics of self-care, social belonging, and service, 12-week course that features a number of different invited speakers, which I'll show you in a second, covering topics around how to harness the science of social belonging, resilience, and public service, volunteerism, connection with others to improve individual and population health, example topics, how to stress social connection, diet, sleep, exercise impact the brain and the body, why are self-care, social belonging, and service, volunteerism, and service critical for well-being, how can individuals, organizations, and communities leverage the science of stress, social belonging, and service to enhance individual and community resilience. We have an incredible group of 25 speakers, first partner of California, past acting Surgeon General of California, David Cabuchon, Dr. Diana Ramos, current Surgeon General of California, a variety of other stress experts, Robert Sapolsky, Alyssa Epple, and a variety of NIH officials and individuals with public health and personal experience. And our final short lecture that we just recorded, Josh Friday, of course, Chief Service Officer of the state of California. And finally, to house all of this work and hopefully to keep it going in perpetuity, we created California Stress, Trauma, and Resilience Network, statewide network of academics, providers, policymakers, and community organizations, the mission being to enhance resilience, promote community health and well-being, and prevent and mitigate negative effects of stress in California. Cross-sector partners to date include 9 UC campuses, Stanford, Santa Clara YMCA, LA County Department of Health Services, Office of Surgeon General, GoServe, First Partners Office, Cal HHS, and others. 5-year overview in a nutshell, developed scaled intervention. Again, thanks to CIAPM, Stress Tracker Research Training Program, MOOC statewide professional network, seeded the acquisition of additional $5 million in support, mostly from federal funds. And we're starting now to integrate that evidence-based educational program in the statewide initiatives. I think we can't sell short the importance of the workforce development and the upskilling that CIAPM created. 5 incredible postdocs, 4 project coordinators, 2 graduate students, 43 undergraduates, and even 7 high school students. Some children were born, some birthdays were had, some awards were won. Thank you so much, David, Julianne, CIAPM, for your support. We're deeply honored. Thank you.
Thank you, Dr. Savage. Our last speaker is Dr. Tucker from UCSF.
Thank you so much. It's such a privilege to be here to present on part of our team. And also, what incredible speakers so far. I'm very humbled to be following the great work of my colleagues. And so I'm excited to be able to present on behalf of the Collaborative Approach to Examining Adversity and Building Resilience program. This program brought together 7 distinct organizations to tackle some of the most pressing frontline questions on adverse childhood experiences, not just on screening and what it meant for biologic pathways, but also how do we holistically respond to families and to the community. And so you heard already about some of the health impacts of ACEs, which are really important. I also want to stress that ACEs or stress also has impacts on important educational opportunity and economic outcomes across the life course. So we know that ACEs lead to learning difficulties and emotional challenges in childhood, is associated with school absenteeism and having to repeat grades. It's also associated with not completing high school. And lastly, in adulthood, it also leads to lower lifetime earnings, whether that's through unemployment or job instability. And we know in the California Surgeon General report on ACEs is that ACEs have led to the cost of over $100 billion annually, both from healthcare costs, but also from just productive life loss. And so this is important when we're trying to think about tackling a problem and not just tackling it because of the health outcomes associated with it, but also the opportunity that is lost across our communities in disparate ways. And so we felt that there was an imperative to think along the prevention lines when wanting to address this. And so the mechanism, the California Initiative to Advance Precision Medicine, is a really unique funding mechanism in that it generously funds innovative research that is really putting the community at the front lines of making the decisions on what should be studied. We thought this was really exciting. We had already built some partnerships in the local Bay Area. It gave us the opportunity to extend partnerships to the Santa Barbara area and really lead with what our Federal Qualified Health Center, FQHCs, were experiencing in trying to implement the recommendations around ACEs screening. And a lot of it was like, great, I'm screening for something terrible. How do I talk to families about this? How do I provide support? This is gonna completely change the appointment from being 15 minutes to being an hour. And let's not even talk about the mandated reporting. How can we do this correctly without traumatizing our patients and without losing trust? And so we took that need that was really required at the front line, and then also coupled it with the need of trying to better understand some of the mechanisms. And so this is not just the biological mechanisms, but also the pathways or the societal pathways that interrupt and contribute to the negative health impacts that we heard from Dr. Slavik and others. And then also, how do we use the learnings that we are building with our partners to accelerate implementation with a focus on lower resource settings where connections are a lot harder to different resources. We heard earlier about the difficulties of getting genetic testing and, more importantly, consultation on those genetic test results in federally qualified health centers. And here we're talking about making connections for mental health or to resources in the community, which is also equally challenging. So to tackle that, we were able to bring together our 7 partners that are listed here from Richmond, California, Berkeley, Oakland, San Francisco, and Santa Barbara, and all together bring together academics, federally qualified health centers, nonprofit organizations, and bring the expertise of implementation science, toxicology, epidemiology, and also the community perspective lens, not just through our FQHCs, but also through the community health workers as part of the team. And I think together we were able to tackle these really ambitious aims that I'm going to go through with you today. And so under our first aim, we were able to leverage an ongoing cohort of 500 children that were recruited as part of the PEARL study. And so from the PEARL study, we had developed a screening tool for ACEs, but also as part of that study, we were able to follow the children over time and collect not just biospecimens of different types, but also important measures of stress, of their social needs, and also of the environmental of their environment. Under our second aim, we were able to conduct a randomized control trial of different child caregiver interventions and thinking about how the delivery in primary care could work. And so really trying to go from your traditional RCT model to one that really thinks about implementation at the same time. And then lastly, there was a lot of focus on implementation. So how can we do this well and create a toolkit that can be usable by different low resource healthcare settings to be able to think about if they wanted to implement ACEs screening and response, how can they do it in a way that's feasible? And so through our first aim, this is one of our early participants, we had a study called the Pediatrics ACEs and Resilience Study where we recruited 500 kids. This mechanism allowed us to add in a 5-year time point. And what we have here is at baseline, we know that about 1 in 3 kids had about 4 or more ACEs. When we first recruited them. And then at this 5th year follow-up time point, we saw that those that had 4 or more ACEs had more reports of poor self-rated health and also almost 7 times more likely to have asthma, as well as being 3 times more likely to have reports of allergies. And so in addition to further establishing these connections with health outcomes during childhood, we were also able to look at the biological responses and try to understand whether or not changes in the biology impacted the response to having childhood adversity and whether or not that contributed to disease. And so this work was done by Laura Diaz, who's an amazing doctoral candidate in the lab of Dr. De La Rosa here at UC Berkeley. Her question focused on understanding whether ACEs is associated with eczema, a well-known common condition, skin allergy condition, and whether or not this relationship with ACEs depends on the activity of the mitochondria. So the mitochondria, as many of you guys know, is sort of the powerhouse of the cell. And this mitochondrial DNA copy number is a biomarker of that activity. And so what we found in the CURLS cohort over time, that if you had a low mitochondrial DNA copy number, your risk of having eczema on follow-up was much higher than those children that had a high number of mitochondrial copy number. So this is starting to show that it's not that the experiences that you're having are getting under your skin, impacting your biology, and also contributing to disease outcomes. So further contributing to trying to define the different mechanisms that stress can actually change your biology and contribute to skin. And it's the diseases, and it's not just coping mechanisms, right? It's not just, oh, you're stressed out, so it's the coping mechanisms or the behavior that's contributing to the disease outcome, but it's the stress itself that is changing your biology and potentially contributing to increased disease. And so it's great to be able to further delineate these pathways, but on the next slide, we thought it was really important to also try to understand what are the different types of interventions that could potentially serve a protective factor to address these traumas that are happening in our families' lives. And so we worked with our 3 distinct pediatric sites in Richmond, Oakland, and in Santa Barbara, and really uplifted some of the work that was happening on the ground as interventions that were focused on the child-caregiver dyadic relationship. All of these groups understood that ACEs make it really hard to parent. And at those times, providing resources that really focus on mindfulness, relationship, and parenting could help buffer and create a more positive environment for the child and potentially have a protective or mitigating effect for families that are experiencing high ACEs. And so each one of these were conceptually tied by those concepts, but their delivery slightly differed across each site. I want to highlight that this is a randomized controlled trial, so it was really important for us to define what the control arm would be looking like. From our clinics, and then also from qualitative work with families and with providers and clinics, we understood that that control arm couldn't be usual care. It was an imperative that we offered something that we refer to as enhanced primary care. So what is enhanced primary care? So it means that we actually asked families about their social needs, and those that had unmet social needs were connected to community resources like food, housing, financial support. So what we were really comparing as part of this study wasn't so much, does this dyadic intervention benefit families? We were asking, is this addition of a behavioral intervention lead to additional improvements on top of enhanced primary care? And so what we found is that we were able to enroll 174 child caregiver dyads. We found that the mean Pearl score was around 2, or mean ACEs score was 2, so a little bit lower than the 4 or more that we often hear quoted, which is a good and positive thing. We randomized them to enhanced primary care or to one of the 3 dyadic interventions. Our main measures were parenting stress, and the second was child behavioral and emotional challenges. And we followed them from baseline 2 weeks post their intervention, and then 3 months after that intervention. And what we found is that the families that had the intervention had a drop in their parenting stress scores immediately after intervention, and that was sustained. And what we found in our enhanced primary care arm, that those parenting stress scores also went down, but it just took longer to go down. For our child and emotional challenges, we saw that both groups decreased over time. And so we think that this, we were excited to see that the whole study population improved over time. And this also, I think, starts building evidence that enhanced primary care, so this navigation, should be tested more rigorously as a potential response for clinical practices where more resourced and time-intensive dyadic interventions may not be feasible. And so this starts to say, maybe there is a floor, maybe there is something that we can think about building into our clinics. And so in our last AIM, we looked at the implementation challenges, and I really want to highlight our Care Family Board, who are members, our families in the different clinics that we were working in. They really contributed to not just adding strength-based questions to our ACEs screening, but also really providing information on what response should look like in clinic, including like what should providers say to patients and what kind of resources they should have. And so we really took their knowledge to really change and guide how we should think about implementation. For our toolkit, we have it simplified into 10 steps. This will be on our website before the end of this month. I was hoping to put a QR code today, but we just didn't quite get there. What we go from is like, how do you make your case as a clinical setting, to everything to thinking about sustainability and funding. And then I'm just going to give example of the algorithms that we created for clinics to think about resource navigation into the community, because that's such a complex thing. And what we did is develop a stepwise way of using the local knowledge to build your resource list, and then use an algorithmic approach as opposed to the, oh my gosh, this person doesn't have food today. What do I look up and try to find on my computer to give them as resources? We actually provide an algorithm. So here are the phone numbers, here are the names based on what your need is today. And we provide a way of doing that that's feasible for clinics across the state. So in summary, this mechanism has really allowed us to contribute to the evidence on ACEs, both from thinking about biological responses, but also thinking about interventions that might be useful for primary care. We also learned tremendously from our community partners and our Care Family Board, and really wanted to demonstrate a model where working in partnership really improves the scientific rigor of your studies, because it increases the relevance for the general population and potentially in translation increases impact. And this is really evident in the transformation that we saw in the clinics that we were working with, and we hope that over time that will have population impacts. And so I do want to thank you for your time today, and also thank you again to CIMPM for having this funding mechanism available.
Thank you, Dr. Tucker. And thank you to all our speakers. We're now going to transition to a panel discussion. So if I can have our 4 speakers and our council chair, Dr. Lajan Sher, come up. Yeah, you can sit in these chairs, and if you don't mind sitting in the order on the slide, that'd be great. Just to... Yeah, can you, Joanna, can you help with them? Yeah, get it. Yeah. We're getting another microphone for you guys that the panelists can just run back and forth. Dr. Lajan Sher is our chair of our advisory council, and I'll let you introduce yourself a little more, and then you can kick it off with the panel.
Thank you so much, David. First of all, happy birthday to CIAPM. Let's talk about that. A big round of applause. And then I want to thank all of the speakers, all of whom are dear colleagues. And I just wanted to kick this off. I'll just say a couple words about me, because that's not the important part. Clara Lajan Sher. I'm the Deputy Director for the UCLA Institute for Precision Health. I'm also a faculty member in our Department of Neurology in our School of Medicine. And I lead several genetics initiatives on our campus. My career has been rooted and grounded in psychiatric genetics for its entirety in one way or another. But I'm a program builder. I see problems, I like to fix them. And I build programs and I develop resources to really facilitate and support the translational research pipeline. And I'm very grounded in our community. Most people can't tell because these are our own biases. Even though I'm genetically European, I'm culturally Cuban. And so for the first 10, 15 years of my life, I called myself Latina. And people would look at me and say, no, I don't think you really are. But I didn't speak English until I was 6 or 7 years old. And for me, it's my culture and its people and it's understanding perspectives that are different. And when it comes to community, that's what we need to do. So enough about me. I want to thank each of our speakers, and I'm going to kick this panel off by asking one overarching question. How does or did your CIAPM supported research translate into real world care and positively impact community? Now, our speakers have already highlighted, each of them has done a really tremendous job, but as we take a step back, what we really want to understand is what's the return on investment of CIAPM and funding mechanisms like this. And we're very fortunate that the state of California has been supporting this program for as long as it has. So, Charles, let me kick it off with you.
Sure. Thank you for that question. It's a very challenging question. One thing I feel that CIAPM did was it really enabled us to take what was developed as primarily a tool in the research setting. I mean, this was basically a test I developed in my lab, and we used it for pathogen discovery. But what we really wanted to use it for, we wanted to pivot to having what clinical impact could it have? Could we actually develop this into a clinically validated test? And I think that was the key aspect of the CIAPM support, in that we were able to demonstrate with the support of the CIAPM that we could launch a clinical trial. We could show that this has direct impact in patients. And the second major thing is that it actually led to providing an infrastructure in place where we could run this type of test routinely in the community setting. And it happened to be fortunate because just when we completed the trial, COVID happened. And so, but we were in a position where we could immediately implement this test. I recall on the very first day when we heard about the cases that were coming into California, I actually gave a call to the California Department of Public Health, which was actually a partner on this project. And we were able to immediately develop not only a testing pipeline for the SARS coronavirus 2 virus, but we were also able to be able to sequence the virus. And by doing so, eventually we were able to identify the Omicron variant and identify the early emergence of the virus into the community, but at the same time, I feel that that information didn't go just into research. It actually it went back into the community. And in fact, we were providing our results in real time to the community. So the California Department of Public Health and the local county health departments could trace the evolution of the virus and trace the spread of the virus in our communities.
Well, that's terrific. And I know Tony Fauci has also spoken about this. So this has been, I think, incredibly transformative, not just at the state level, but also at the federal level. Isabel, same question.
Got one more. Yeah, there you go. We can do that too. I want to say thank you very much to the CIAPM, first of all, because I spent many different days with you in different ways, and always appreciated and loved the work of CIAPM, and grateful to the state of California for supporting it. My dear colleague Manali Patel is at Stanford and was our lead on this, reminds me this is a celebration. She thinks I'm a little doer. She thinks I'm a little, but I said, well, you know, perspectives are different. And when you come from community, you see very differently from a different way how things are impacting. And you measure success by how your community is feeling, not whether, you know, the research has done something. And so I look at, did it have a small impact or a large impact? And I think we set the table for what should be duplicated and triplicated around the state and around the country. But as Manali says, due to CIAPM, people are, where we are left in the Monterey County and at the Cancer Center, the people are getting precision cancer care. They're getting tumor testing. The CHWs remain in place, which is good. They did pick that up and they're being reimbursed by Medicare. And all of those are problematic when we're trying to duplicate these services, even as critical as they are to people. And I think really even more exciting is some of the CHWs have gone on to more education. One is becoming a doctor. So, you know, there's all of those wonderful opportunities that evolved. And I think that it centered, CIAPM centered community voices, either the patient, the community health worker, or the community-based organization. We were all able to have a part and a say in how we saw success using this thing called precision medicine.
Thank you, Isabel. And I think you mentioned something that's very important. Each stakeholder is going to have a unique perspective. And so we have the academic researchers. They're going to have a unique perspective of success or failure. We have community members that are going to have a unique perspective about success or failure. And so I think we have to make sure that we also align these metrics across the ecosystem. I think that's also very important. So thank you for that perspective. George.
Go Bruins.
Go Bruins.
Let's see. Imagine yourself as a quote-unquote average community member in the state of California across different geographic regions, living in Shasta County, living in Marin, living in San Francisco, living in Los Angeles. The barriers to receiving high-quality, evidence-based stress management is high, very high, for different reasons across all of those regions. If you're in Shasta County, you may not have a provider nearby. If you're in Marin, you may not have a provider who takes insurance. You may have 4 to 6 month wait for a behavioral or a mental health care professional. If you're near Los Angeles, you may not be able to get to that person because you may have to drive 2 miles that takes 2 hours or something like that. The barriers for receiving high quality care are huge, and even if you can find a provider, they may not be available or you may not be able to afford it. So I think the first thing we did was what I think is transformational is try to create high quality, self-paced stress management care in the comfort of people's homes. It costs little to nothing to replicate, it works well, and people can do it wherever they want. We find that healthcare providers don't want to screen for ACEs because they feel a more obligation to do something about it. And if they can't find a referral option, they don't want to know about the problem. I personally disagree with that, but I can understand why they don't want the moral burden of not being able to provide a referral. So this solves that problem. In terms of clinical trials, whether we want to talk about it or not, most clinical trials are extremely homogeneous. Sometimes they tend to be racist, they tend to be sexist, and they tend to have populations of people who can afford the time or the money to come in to a major academic medical center. Why? Because that's where blood draws are done. That's where physiological assessments can be done. That's where treatments occur. Well, if you have the resources, the time and the money resources to come into a clinical trial, to come into Stanford or UCLA, et cetera, you're probably well-resourced. So many of the clinical trials, as we know, are based on very homogeneous populations. I think the second transformational thing that we've done is we tried to figure out, how do you do a clinical trial at scale in a totally decentralized way? How do you assess everything that you would want to assess in the clinic, but in the comfort of somebody's home? And the way that we did that was by this beautiful unboxing process. We put everything in a box, we sent it out to the participants, and those participants hopped on a Zoom call, and a research assistant walked the person through how to unbox all the widgets and gadgets, and didn't get off that Zoom call until that person knew how to take their own blood, how to take the stool sample, how to wear the wearable watch, et cetera. So I think in those two ways, we essentially brought the research and the treatments to the community.
And that really is beautiful. And when we think about COVID, we can all identify all of the negative things about COVID. But what it did do is it was a paradigm shift for how we do things. And George, you've just outlined how critical and what a unique difference to send it. It's science in a box, and you send it to them, whether it's the watch that they're wearing. All of us now know how to do COVID testing in the privacy of our own homes. And I think that was transformative for, I think, across the research sector. So thank you for that. Last but not least.
Yeah, I think our study was really unique in that so just let's set the stage. So just a year before, the recommendation came out that ACEs screening should happen for pediatric primary care. At the time, very few clinics were doing it or knew how to do it with the right resources. And we were uniquely positioned because we were already working with partners in the community. So these federally qualified health centers, particularly two of them, so Santa Barbara neighborhood clinics, and then the UCSF Benioff Children's Hospital, Oakland, who are already doing great stuff, like great interventions, working with families, doing these dyadic interventions. And so through this mechanism, we were able to uplift the community-centered approaches that were happening and be able to bring our implementation science sort of hat. Like, how do you say, what are the key components of these interventions? How do we build this into workflows that are happening in clinical practice and implement it and test it at the same time in a rigorous fashion? And so Richmond, with our lifelong medical clinics, was one of our colleagues that weren't doing ACEs screening or response at the time, but were really eager to. And so we were able to use the learnings from the experts, so our partners at the FQHCs, bring those learnings to Richmond and all talk about the challenges, everything from how do you do the screening reimbursement? How do you talk and refer this person? How do you get them engaged into the intervention? And how do you do this enhanced primary care that I talked about? And really be able to uplift that. And there's not a lot of opportunities to do that. And this mechanism allowed us to do that. And then we were able to take all of those learnings and create a toolkit for implementations for other settings to be able to do something similar.
That's terrific. And it's really incredible. Each of you has outlined different ways that you have impacted community. Because I really, this is not research for research's sake. I think the challenge, each of you is an implementation scientist in your unique ways. And it's how do we move from that lab and get these interventions to patients, because each of us is a patient. So when we talk about community, we're talking about ourselves within a broader community. So thank you. So the next question, and I think each of you has already touched upon it, but if you could highlight, how do you see the return on investment for California? from your CIAPM grant? And Charles, I know we've already, I mean, you've gone beyond the borders of California, and, you know, each of you has, I mean, that's what research and the literature is about. But how do you see the impact, that return on investment? So from the state perspective, for them to say, wow, this is a real win for California, how would you address that?
Yeah, a couple of things. One is that the test that we've developed, I'm happy to say, is available to all patients in California, and it is now, it's being run by, or at least we process samples from like all of the UC major medical centers. But one of the big challenges has always been, you know, how do we provide for, say, the disadvantaged and underserved populations that are disproportionately affected by infectious diseases. And one of the key questions I always get is, what's the cost of the test? And, you know, the issue is, it is an expensive test. I have to be out front. It's a quite expensive test. Now, you can decrease costs by essentially scaling up, so you can decrease costs, but I firmly believe that the way to actually make this more accessible is to actually decentralize the testing. So we've been doing two major efforts in that area. One is that we've developed a test that was originally a manual test that had 300 manual steps. Our laboratory scientists were getting carpal tunnel syndrome, basically, as a result of running the test. But I'm glad to say now that's entirely automated. And in fact, the analysis is even being done on the cloud, essentially. So we have a completely automated solution. But the second thing is that I firmly believe that we need to get FDA approval for the test. Because in that way, once we have FDA approval, it's more likely that we can have the test reimbursed. So ultimately, in the future, I hope to see this test being able to be run by every hospital lab in the state and certainly in the country in the future. And it would be fully reimbursable, meaning that it would be accessible to everyone in the community.
Thank you. Isabel?
Well, I had to think that one, glad to think about it. But I realized that what California has done, that we have seen a major shift around the rest of the country, is a commitment to diversity and inclusion. And I'm, yes. And beyond that, what I really loved, which I mentioned before, was that they also put the bucks behind it, and that is they required and mandated that there be community partners, and they gave them equal amounts of equity dollars so that they could participate. Because, you know, too many community organizations want to participate, but just don't have the bandwidth, you know, and the dollars to be able to give it their 100%, if not 110%. And yet I know they will. And so I think that that sends a loud message, and hopefully continually with our legislature and any new governor, that this is an important achievement for the state, showing that it is in fact democratic.
Excellent. Thank you so much. George?
I just want to pick up on that point. I think funding the integration, funding community-based, community-integrated research is so important. The funding is important. I was invited as a scientific expert on a moonshot project for an NIH institute, which took 25 hours of time, which as an investigator was a lot of time. They expected the folks from the community organizations to put up the same amount of time, all in kind with zero funding. And I think that, in fact, the problem is not that sexy or interesting. It's pretty fundamental. And how can you take 25 hours away from your daily schedule, you know, to participate in such an important endeavor? So I really think that's critical. I think for us, the value to the state of California is multifaceted. One is about education and awareness to the general public. I think on a topic that Nita and I are studying, stress, it is self-evident, but there's a lot of public awareness that is important in that area. Two is workforce development. Right now, as we all know, we're not in a place where the federal government necessarily has the will to foot the bill for upskilling or for workforce development, and I think that's very important. We all, as Dr. Lacher said, stand to benefit from healthcare providers and from the next generation being trained in the fundamentals of biobehavioral research and clinical care. And hopefully, you know, as this intervention gets picked up, we can have more accessible, low cost or no cost options for stress management, which we all, I think, live and breathe on a day-to-day basis. So.
Thank you, George. I just want to comment. You know, you had mentioned earlier how often, and I know it's happened every single time that I've submitted a grant, that oftentimes, whether it's a clinical trial or any other research study, it's about checking a box, but that box is not really important when it comes to authentic inclusion of underrepresented groups. It's, yes, I'm going to check the box. However, there's no money behind it. There hasn't been money behind it. And I think, to your point, money, and also to what you just said, Isabel, it's really about funding that very critical piece to ensure that there is equitable representation. And it's not just because it is the right thing to do. It is because it's essential to innovate and actually do good science. I mean, we're constantly reading now about genetics and precision medicine and how important it is to have these diverse populations represented, whether it's in biobank research, genetic research. And there's a reason for that, because that's going to have downstream effects on the treatments, the interventions that are going to best help patients. It is the right treatment for the right, I know it sounds cliche, but it is the right treatment for the right person at the right time. And the other thing I want to just sort of follow up on is a plug for really the workforce. When I first became involved with CIAPM, then Governor Brown had really, and Julianne was there, and he really commissioned an action plan. And the state identified a group of stakeholders that they really thought, the experts that could come together and identify what are the key issues in order to launch a precision medicine initiative. And a huge piece of that was workforce development. I think we're all tired of hearing that primary care docs don't understand genetics, or that doctors really don't understand anything beyond 23andMe, and even that is a little foggy. But part of that is because we're not developing the workforce to do it. And I just want to put in a plug for CIAPM. They have an incredible RFA they've moved beyond it. But it really is a fellowship training program to identify and really provide that training to young stars and these young minds that can really accelerate science. So just wanted to follow up on that. Thank you, George. Nita.
Yeah, so, you know, similar to George, we really explore different ways of bringing research to community. I think different is that we, instead of thinking of delivering the box for collections, we actually set up our infrastructure within the federally qualified health centers. And so we had research team members or funded team members on the FQHC staff to be the coordinators, to be the ones collecting the blood and doing all that, because we knew that these centers were viewed as trusted partners by the community members, and really built on that trust to help facilitate engagement, not just with our interventions or our follow-up, but also with research in general. Because this was an opportunity to also talk about what research is in community, and really think about how we can use research to answer questions that are important to community and build that into our research questions, which I don't think always happens from academia. And so I really appreciated that this mechanism puts that at the forefront. And so as a result, our study population is 100% reflective of our communities. And so if you look at the proportion of people included in our study and compare it to what does the clinic population look like, it's the same. And so we have representative research. And so that means that the results are going to be generalizable to our communities that we are serving in a way that I think our traditional RCT that is done in the ivory towers is not. And that has a huge value and also has a larger impact in the long run. And it's really, really positive that this mechanism is continuing, particularly when federal dollars are decreasing for representative science.
Glenna, can I?
Yes.
Because I really wrote this down, I need to. But it goes to this whole point, so thank you both for also setting it up. You know, not only do I appreciate the equity funding, but I think that when you allow CBOs to bring their team aboard because you can afford it, you grow their capacity for research knowledge. It spreads the understanding of research, its functions, and frameworks of engagement. It grows belief in the need for research, moving to trustworthiness, which is where we always have that issue, trustworthiness to trust. As importantly, it can excite the curiosity of team members to begin asking their own questions. This is one of the things I really want the community to recognize. They can ask the questions, and together you can find, you know, solutions, or at least lead communities to an answer that helps them implement something within their community, not waiting for the total answer, right? For the total research answer 5 years later. So that's really critical. And finally, if the study itself is successful, it leaves behind something for the CBO to implement, you know, either change or uptake in a better practice in community. So there's an opportunity there, and we're all so much better if we're all engaged in this in one way or another. And then finally, to Dr. Patel's point, we hopefully move some of those kids and excite them to become those scientists of the future, to move into, you know, into the PhDs and the medical doctors and the oncologists, et cetera. So I love this program, and I have great pride in it that I am part of it. So, and I want the community to feel that as well.
Thank you, A7. One of our final questions now. Let's be a little future thinking. So we're all excited and proud of the work that that each of you has done and that the program has done, and we're grateful that the state that they invested, because this has been a significant investment. Looking at the future, where can CIAPM make strategic investments to maximize impact on precision medicine for all Californians? Because, and to your point, you want to make this test affordable, and that is really critical. If we can't limit the science to the 1% who can afford it. So let's start off with you.
Yeah, so I really see a huge role for AI in the future. I can tell you that we're actually going back to our data, and we're developing these models. We're using the fact that we've collected what we call big data. We've collected very large databases of all different types. I mean, it's not just omics data, but we're talking, you know, biometrics, we're talking demographic data, clinical metadata. All of that data can be leveraged with AI to actually be able to develop better models, better ways to diagnose disease. And I really think that, and one thing that I quickly noted is that what's really important is that everyone's involved, that everyone actually contributes to the data. When I went back and I tried to develop models based on our one study, so we had one study that was supported by the CIAPM, 200 patients. We developed models, and they worked somewhat, but they weren't that great. But when I incorporated models that came from our patients, that came from all of the patients in the community for which you know, they provide their data for us, we developed models that were extremely accurate. So in this way, you can imagine the future that as we collect data, and of course, we have to realize that, you know, the data is very important. Data privacy and confidentiality has to be preserved. But I see a lot of potential in having the ability to share all of this data on a community-wide level. Different types of data that eventually we can use AI to develop better models, better treatments, better diagnostics. And it's my hope that all of our efforts here can contribute eventually to this kind of effort that we have to really cure all disease. I mean, really, I would love to see kind of at least some initial efforts being made to just being very ambitious in that respect.
Well, I was going to pass, but it made me think of something, you know, that not just about prevention. I'm a prevention girl. despite all these fabulous and wonderful advances we have in precision medicine and stem cells and, you know, gene therapies, I want to catch people early. I want to diminish risk. That saves the dollar, it saves the human, and it saves the system, right? So it's maybe, a big dream. But the whole point is, I would love that this big data helps us educate the community so we can intervene early, so that we can diminish that risk and we can stop that fourth stage tumor from being there as opposed to getting them. And this is where I continue to try to center my work. But I love the data, and I need the data in order to show my community what is impacting them, and then hopefully we have answers about how do we approach it from our end. The state, in allowing all of this to happen and allowing us to partner and allowing us to share, which wasn't always the case, right? Sharing data was not always the case. It really becomes critical for the community to be able to get that as well. I sat on the All of Us research program for the NIH, and they talked about having this big, broad laboratory database available. And I said, so can the community get it too? So we can ask the question. And they thought about it, and they finally did. And so we have this thing, you know, this ability. Well, they said they do it. We haven't implemented yet. But one of the things was that they've made it so complex to access the system. You have to have the big bucks. You have to have the big system because you can't even download it. You have to work in the cloud. So, you know, it's one thing to have good intention. It's another thing to make the pathway approachable. Because there, once again, if a community can get in there and ask a question and play with the data and start to learn, you know, what this really means, it's about them and it touches them, then they want to have more agency in it and on it and be more, we're not helpless and we're not hopeless. We want to be part of this engagement. And if we can lead it with all of this wonderful research that's coming out, I think we've really made great strides towards, once again, democracy.
Thank you, Isabel.
Only one mic. I think the first 10 years is the CIAPM pioneer phase. I think CIAPM figured out the model for identifying the most important and pressing moonshot projects, for identifying incredible investigators across the state and community organizations to do the work, how to make sure that the projects are moving forward, and how to make sure that they're hitting the deliverables. That is all about pioneering new discoveries. I think the next 10 years is all about exploitation. It's about how to figure out what all of the gems are, the discoveries across all of the projects that already have been done and have yet to be done, and to make sure that those discoveries see the light of day and go directly back to the taxpayers who knowingly or unknowingly invested in the pioneer and discovery phase. And so my open question is, do we have a process? Has Cal HHS, other agencies, have they stepped up, and are they at the table in order to ensure that there's a process by which the most important discoveries that have already occurred or that yet will occur have the possibility, or that there is a pathway to adoption and integration? I feel like that's looking forward into the future. California taxpayers have put up the money for those discoveries, and now we all in this room and outside of this room should benefit. So let's let the people of California be the first people to benefit from those discoveries if we have a translational pipeline to make it happen.
That is so true. The infrastructure. So what happens to research when the grant ends? And so do you develop a company? And can everyone have access to the test? Do you develop an intervention? Is it copyrighted and not everyone can have access to it? Or does it require specialized training? What's the process, the infrastructure, the workforce that's required to bring this to our communities? So thank you. Netta, what are some thoughts?
Yeah.
Tell us about the future.
So I think there's two areas for potential expansion, and one of it builds on a concept that's been being brought up. So Charles, you mentioned affordability. Isabel, you and I earlier were talking about the systems and the policies that need to change, and then George, you were just talking about how do we translate our findings. And I think including a concept of policy in the mechanism, so research to policy. So you have made these discovery. Now, what is the policy that you want to change? Or maybe even starting, this is a policy I would love to see in place, but these are the existing gaps, and our research study is going to address it, and then work to create the policy brief or the legislative action that could be considered by our state lawmakers. And so that's one way of thinking about how do you ensure translation of research as you build it into the mechanism. So thinking about community, research, policy, all in one mechanism. The second is these last 10 years, we have also developed amazing computational methods, right? Like the methods that are required to understand complex biological systems, to be precise, to identify new genes, to identify new pathways is incredible. We should be asking for the same sort of, to ask for these methods to be applied to the concepts of precision public health. And the reason I say this is that we were talking about this in both of our presentations where, you know, there are things that can happen at the individual level, but our communities, particularly those that are medically underserved or more socially vulnerable, can't take advantage of it, whether it's through lack of insurance or dealing with complex social issues. And so we should be using the same scientific discovery with regards to our computational methods to think about precision public health and how do we better understand the mechanisms of upstream factors to what's happening locally and where can we make impactful change based on local context and community expertise and lived experiences.
Wow, I mean, ChatGPT couldn't have said that better. That is brilliant. So I want to applaud you for that because that really ties everything together. And I think it's incredible that here we are, the seat of government, we're in Sacramento, and I think a part of this that all of us has been sort of, if not alluding to, saying outright is where are the lawmakers? And what can we give lawmakers? What's the information, the nugget, the recommendation to lawmakers to move towards policy? Because we know policy doesn't happen overnight, but it is a critical part because if the lawmakers, if there is a policy, I mean, Charles, you just said if this test becomes reimbursable, then all of a sudden that's a game changer right there. And so how do we take what we are learning, discovering, how we're innovating, and really help lawmakers understand what it means and what they can do? Because we're talking about partnerships, but I think lawmakers are also important partners in this ecosystem. And also, it's another stakeholder. So it's a beautiful way of wrapping everything up. I think with the advent of AI, there's an opportunity there to see how we can, in all of your projects, there's a role for AI, there's algorithm development, and ethical AI is incredibly important as well. It's not the future, it's here. And so I think it's also going to be important for us to think about how we can all leverage that in science in each of the areas that we live and work. So I want to thank each of you. This has been a wonderful panel. It's been incredible fun, and we could probably go for it, keep going. David has something to say.
It is going to keep going. We have about time for about 2 audience questions.
Fantastic.
Yeah, so that's what I wanted to say. We have a microphone going around in the room, and then Ramon has a microphone to relay any Zoom questions.
Yes, if you have any Zoom questions, please feel free to raise your hand.
And in the room, if you have a question, you can raise your hand. Yeah.
Hi, everybody. What a wonderful discussion and presentations. So I'm Sheila James. I am here personally not unofficial NIH, all of us business, because we can't travel. But I live in Stockton, and I just had something to do in Sacramento today. But, Isabel, you gave me an idea. Real return of value it just occurred to me, we're no longer giving DNA results and tests and things like that. But what about teaching participants, communities, how to use the public tier and understand how to apply those data to themselves and maybe their family if they have a question. So I have to figure out how to take that back, or get somebody to take it back. But it just reminded me and was an opportunity to think about how can we expand return of value and what that means. And it's not always, a $25, gift certificate. So thank you for that inspiration.
Thanks for that. Thanks for that question, Sheila. I think this is one of the reasons why I want data to be available to the public, to a community that's struggling with something very specific, a disease or a concern, so that they start to feel comfortable with the data to turn it into the argument to impact the policy that gets changed in the system so that they can right the wrong. I mean, literally, sort of like where you were going. I tried to make it a little more simple, but bottom line is, and I think data and information are so critical to our communities. Their lives are so engaged with so many things, trying to stay on top of their heads above water, that oftentimes that's the challenge, to go that extra mile. But as a former journalist, I love information. And I think there's nothing more critical and more golden than communities having information in their hands that they can understand, that they can put to good use, and that they can help make a difference. They have agency in their own lives, and they're not feeling like they're dependent on somebody else to save them. They can try to gather to save themselves. And if you can come up with something, let me know. We'll see where we go. But we need to open up these systems. We need to open up access to us, which is why I said we have to keep giving the community a chance to ask the question.
And I think that's really beautiful, because the ivory tower, academia, I often work with a lot of basic science researchers who want to do this research project that they think is the most important thing in the world. And then when I pair them with the clinician's like, that's not a big deal, like that's not a problem. So there are a lot of people that have a solution almost in search of a problem. And it's really, and my work in the nonprofit and advocacy sector, if it taught me anything, it's let the patients, community, parents, whoever the stakeholder is, tell you what the problems that they're facing are, and then you as the scientist can work with them to develop the appropriate research studies to be able to answer those questions. So it's a balance between there is expertise, scientific expertise that academia has, but the problems really, the community can really do a lot to help identify what those issues are that are most important to them.
So David, can't you, I can yell very loud. Can't you amend the mechanism to actually allow the community to apply to ask the question? They bring the researcher with them, but you shift it. I tried to get NIH to make the same change. Create a mechanism so that the community can come in, CBOs, to your point, they ask the question, they get the money, they lead the researchers towards exactly what you're talking about. And I think it's about everybody afraid to give up that power of purse and the leadership. And I would love to see what an engaged community-based organization could do with the power of research behind them. I think it would be fabulous. So maybe there are already examples. I shouldn't,
I mean, the NIH did fund earlier the compass mechanism, but yes, I think it's maybe a starting point, but definitely agree that it could be better. the administrative hurdles that, that state and federal funding put up
Yeah.
make it very challenging from a fiscal standpoint for small CBOs to apply. So, but yes, I 100% agree that, there should be mechanisms where CBOs can lead, and we as researchers come in as the technical expert, is what I call myself all the time, and support the research, support the questions that are being brought up on the ground.
We have some questions from Zoom as well.
Charles had something that he wanted to, did you want to answer or provide some comment? Are you sure? Okay, all right.
All right, we have two Zoom questions, one from Dr. Tony Young. I'll allow you to talk first, and then afterwards, Maruti Mishra.
Hi, thank you very much for the excellent presentations. And I also wanted to personally thank CIPM for the funding, which allows for us to do research which otherwise could not be done. I really liked George's question and also the other panel's question about trying to translate sort of the initial findings that have been supported by CIPM for the first 10 years. And, you know, how can we try and find additional funding, or can we advocate somehow, or maybe involve the state legislature to give them and share with them our ideas of how we can translate our initial findings from the first 10 years into findings that can then be translated to help the community and public in the state of California. And the second question is that we have a lot of really wonderful funded projects and results, and to perhaps suggest to the state if there's a way to fund innovative collaboration among the CIPM investigators to also translate and do projects that can help the California state.
Tony, thank you. Those are great questions and comments. George, did you want to comment on anything?
I would say, to your point, Claire, that we need an effective process by which policymakers and stakeholders who have the ability to implement are fully briefed on the learnings from the scientific projects. I think without them being knowledgeable about the discoveries that CIAPM has made, we don't have a chance for that to be implemented. And I think CIPM already synthesizes that information. So I guess then the open question is, to what extent is it, is it really being fully understood and appreciated by lawmakers and by other stakeholders? So if we don't, I haven't participated in a CIAPM-led showcase, scientific showcase to lawmakers. Of course, lawmakers have to show up, and other stakeholders have to show up. So I don't know that we can't control that, but those are things that I think agencies could facilitate, other than just synthesizing in reports, et cetera, but actually doing convenings where folks are around the table and experts, technical experts, are describing what could be translated, and lawmakers and other stakeholders are asking questions and figuring out, and also discussing what the blocks are from their side, which oftentimes are totally non-scientific blocks. They're policy blocks, reimbursement blocks, other things that need to be solved. So I think forums, convenings, getting the right stakeholders at the table together, that's at minimum, I think, what has to happen.
Here, I completely agree. And we have done, earlier on, we did a lot of legislative briefings where we would go and meet with lawmakers and talk about either the program or some initiatives, or they give them an opportunity to ask questions. And so I think that could be very powerful. I completely agree.
I did one of those.
Yeah.
Julie just.
Yeah.
Juliana. Yeah, no, and let me tell you what I told them. I said,
because she had a lot to say.
No, but one of the things I told them, and I still talk about this because we talk about the value in investment and return on investment. And I said, think about all of the members of community who have participated in this research. You don't pay them. You can't pay them, whether it's even an ethical question, but how about, I said to the lead legislator, how about if you start a community fund based on reinvestments or dollars? Every dollar that you give to, a company investing in this technology or advanced medicine, I said, they give you back a penny that goes into a community fund, and that's the mechanism where the community can apply to ask the question. Of course, you have to, I don't know how long it's going to take with pennies to build up enough money to provide it, but it is really about reinvesting community's time into this. Their money's going to something they want to know directly, right? So it's just another thought I had, but that's what I told him to do, and that was years ago, and he obviously didn't listen to me.
David, did you want to answer the second part of the question?
I was going to actually close the panel. We're running a little behind on time.
I believe there was a second question.
We don't have the time. I'm sorry. Yeah, we're running like over 30 minutes over time. So thank you, Dr. Lajan-Sher. Thank you to our panelists.
Thank you very much.
And wanted to introduce Undersecretary Corinne Buchanan for our closing remarks.
Thank you very much, David. Hi, folks. Nice to see you. So nice to be able to be here today to get to hear all of these awesome presentations. Hi, folks. Thanks, David. Thanks for being here. Thanks for all our friends on Zoom. We appreciate getting to hang out with you today, even virtually. I'm Corinne Buchanan. I serve as the Undersecretary here at the California Health and Human Services Agency. And as David mentioned, I previously got to serve as a member of the council. So it's especially heartwarming to be able to be here today to celebrate 10 years. So our California Health and Human Services Agency is home to 12 departments and 4 offices. And so when we learned that we were going to get to be the new home of CIAPM, we were quite excited because we really see this as being able to help us, again, this transactional nature of the work and trying to figure out how we can bring what we learn through CIAPM into practice. So our departments include the Department of Healthcare Services, the California Department of Public Health, our social services, because as we've discussed today, social determinants of health are a big part of the outcomes of Californians up and down the state. So our mission is to work with cities and counties and communities to be able to bring together many partners to make California a vibrant and inclusive place to live, play, work, and learn. I want to sort of bring us full circle by highlighting a couple of the ways that the work of CIPM ties so integrally into the goals we have at CalHHS. And 2 of our guiding principles are using data to drive action, and another is seeing the whole person and helping that to drive policy and programs across our agency. And I feel like the examples that we heard today just align so clearly with what we're trying to accomplish at CalHHS. The goals of precision medicine by focusing us on interventions that will help us get to that whole person model of care through ACEs, through community health workers, and figuring out the ways that we can reduce disparities just came through in each of the presentations today. So thank you for making that point very obvious. I want to share that today's programming has really showed how much has been accomplished over the last 10 years. I don't know about you all, but I love a good infographic. And I just love getting to see all of the cool work all in one place. So we're talking about mentorship and leadership development. The infographic showed our publications, the press, the patents, the clinical trials, and the new technologies and approaches. And it was just really, really cool to see all in one place. Again, see this as a really important way to leverage California's leadership in biomedical research and health equity, and to help us reach our goal. Our longstanding and what we will continue to do at CalHHS, which is to drive a healthier California for all. I had a really a fun time sitting next to Richard Figueroa from the governor's office during this presentation, because we got to keep whispering to each other about the things we thought were most cool. And before he had to depart, he just wanted me to share with you all that, what the governor was really excited about and has been excited about during his, at this point, 7.5 years as the governor, is how we again can turn this work into something transformative, and that can really be delivered to the people of California. And again, I think we saw that through many of the examples. And this isn't even all of them. What you saw today isn't even everything that's been accomplished, but that was very clear. And then what he also wanted to share was what I think we've been able to talk about a lot, especially in this last panel, is the importance of representative research and how he really understands that much of the research that has been done is not representative of the 2/3 of Californians who are people of color, and how important it is that we're raising that. To all of the amazing grantees who are doing work to create a healthier California for all. Thank you.
Thank you, Corinne, and sorry to play the Oscars music on you guys in the last question. That concludes our event today. For those in the room, we have food for reception in the back, and for those folks on Zoom, sorry, I should mention that the food is courtesy of the California Biotechnology Foundation, a really important sponsor that helps us out with some events from time to time. And for those on Zoom, you can sign off now. This concludes the virtual programming. Thank you.
Woo! All right, thanks everyone. Thank you.
All right. The hard work.
Are you teaching? No, I teach 3 in the fall. I get look forward to spending more time in that with you right now. This fall, the third one is not that bad. Yeah. I heard also everybody finance on those. That's what I'm concerned about. They want more mentoring and guidance in their pace of life. How many graduates? We have the UCLA. I only have 2. Now I'm going to be graduating. And then I'm going to one. She's very different project. I'm getting into Explore. Yeah. She's doing